Hello, everyone. My name is Diana Tran, and I will be going over pressure ulcer prevention, plan, do, study, and act. So the plan or the issue identification, the plan is to reduce pressure ulcers at Fountain Valley Regional Medical Center by at least 50% through prevention. Monthly hospital-acquired pressure ulcer incidence data collected showed fluctuation. Pressure ulcers are preventable. Pressure ulcers are growing in incidence. Pressure prevention is important because it protects patients. Also, it reduces cost of care, and uh, pressure ulcers can also lead to infection. And treatment costs are as high as 11 billion annually. So it's very important to prevent pressure ulcers. It raises the costs for the hospital, as well as Medicare does not pay for hospital-acquired conditions. So the plan or the quality variance is that when this preventative measure plan is implemented, it would be expected to reduce pressure ulcers by 50%. Once the program is implemented, at least 30% of the patient population was prevented from having pressure ulcers. So the expected, which is 50% minus the actual, which is 30%, will be about 20% where patients will be missed from the prevention program or that were not included. So the root cause analysis. For the plan, we did the flow chart, which was where when the patient gets admitted, we conduct the risk assessment using the selected tools such as PUP or the Braden score. And from there, we assess for the activity, mobility deficit, moisture incontinence, and nutritional deficit. And if they're at risk, we follow the recommendations, prevention methods, and if they're not at risk, then we just reassess and monitor. This flowchart was adopted from one of the websites that I found that I felt was really good for this project. Another root cause analysis tool that we used was the fishbone diagram. And this one goes through the different root causes that could have created the acquired hospital pressure ulcers. It's a little bit hard to see, but one of them is like people, and it's either families are not educated, education and training for the staff. Also, with environment, it could be that the patients were exposed to wetness. And then as far as equipment, maybe not enough mattresses and heel lifts were provided. So the planner scope, the stakeholders that were involved in this plan was the charge nurse, Micah, that I worked with, and also the RNC, house supervisor, CEO or CNO, the wound care nurse, and the chief of staff of the residents. So the scope of the problem, with all these players that are involved, this will provide quality of care delivered to the patients on the telemetry floor and process of preventing pressure ulcers through standardizing the workflow of the staff. So the steps that will involve these stakeholders are that the CNO and the CEO and the CNO is needed to stress the costs in preventing pressure ulcers to the RNC. And then the RNC would then stress the importance to the charge nurse, which would educate the nursing staff on the frequent assessments and process in preventing pressure ulcers, and the methods and guidelines for the staff. A wound care nurse will then come to educate the nursing staff on how to assess and stage the ulcers. And the chief of staff will educate the residents on monitoring and ordering nutrition and pressure reduction methods that should be carried out by nursing staff. So the plan or solution, so the solution to the problem is to implement workflow or staff education and standardize the process of preventing pressure ulcers to the unit. And the improvement goal would be reducing pressure ulcers by 50%. So there's a couple studies that I looked at. One study was that the staff was educated on the pressure ulcer prevention, and then risk and skin assessments were done within 6 hours admission to the hospital. And the skin assessment, every time they reposition the patient, they would document and assess the skin. Also, there was a PUP team in the ICU that developed a system that I thought was really, really neat. Traffic light colors, red, yellow, green, and they were put on the doors of the patient's rooms for all healthcare workers to see, so they can identify which patients were most at risk easily. Another study was that they developed a pressure ulcer risk assessment tool to identify which patients to target. Because sometimes there's patients that are walking and talking. Those don't really require the pressure ulcer prevention methods because they're always up and moving. The ones that really, really need it are the ones that are bedbound or incontinent. So that tool is really good to identify which patients really need the prevention methods the most. A third study was done by Clark, and they were replacing mattress stocks with low-pressure foam mattresses. And the result was they saved the hospital $100,000 in the first year of implementation and also reduced pressure ulcers. So a solution implementation. So the do part of the plan, do, study, and act plan is to pilot a test on the unit for 1 month to educate, communicate, inform all the staff of the plan, evaluate the cost and effect of the change, and the data would be collected on the unit and then analyzed. As far as educating the staff, this means utilizing waffle boots, pressure reduction devices such as pillows, pressure relieving beds, like VSP 500, and then turning patients every 2 hours. And also reminding the staff to do frequent skin assessments for the month. In addition, we would closely monitor patients with incontinence, because those are the ones where they can get dermatitis or just the moisture from the pads, and their urine can create redness and tenderness. So in detail, the steps that would be taken are that the CEO and the CNO will meet with the charge nurses and the RNC to stress the importance on the pressure ulcer preventative measures. Then the RNC will give charge nurse guidelines to educate all nursing staff on pressure ulcer prevention, as well as have a wound care nurse come to demo how to assess for pressure ulcers. So this study will go on for 1 month, and upon admission, the patient will be assessed by the Braden score and then categorized as high, moderate, or low risk, and it would be identified on the patient door. Also, there will be a chart in the patient's room that will have a checklist of every 2 hours to mark off when the patient is turned. And someone will be keeping a track of that. Also, waffle boots will also be utilized on moderate and high-risk patients according to the Braden score. And the data will be collected and patients will be tracked on how many times they have been flipped or turned. So the analysis or study part of this plan is that on the floor we have a total of 30 patients for the pilot study. So the data measurement is the number of patients turned every 2 hours divided by the number of patients at risk, which equals the percentage. So the data shows that out of 30 patients, only 20% who were flipped showed that they didn't have pressure ulcers. And the analysis is that the goal was met and it was effective. So in having an effective study, this did increase quality as well. And the last step is the ACT. So overall, in general, the leadership actions that were taken were staff training, promoting culture of non-acceptance of pressure ulcers, promoting best practices, and encouraging frequent assessments. Also, some other actions to take are also patient and family education and the measurement of the data and effectiveness of the implementations that were taken. So what needs to be changed about this whole plan? Well, overall, the test delivered great results. There can always be modifications to improve the plan even further. And with all plans, it would be best to always reassess and evaluate and see if there are other gaps that need to be filled. Implementing change of mattresses incorporated with waffle boots and color indicated risks on the patient doors. I thought that was really, really, really great because people can just identify which ones really need the most attention. And also, this plan should be implemented to all the units close by after 1 month duration and re-evaluated every 2 weeks for 3 months. And then the data will be collected to see if the plan should be spread throughout the whole hospital. And these are the references that I used for this project. And that concludes my presentation. Thank you so much for listening.